from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall,
Welcome to today's meeting of the Health Committee. Members of the public may like to follow at London Assembly on social media and use the hashtag AssemblyHealth for this meeting. Please may I remind participants to silence all your devices. And the main item on the agenda today is dentistry in London. For members of the public watching, please look out on the website soon for our public survey where you can give your experiences of dentistry in London and feed into our wider investigation on this issue. However, we have a few short items of business first, so can I now ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. No apologies for absence have been received today.
Thank you. And can we note the list of offices held by Assembly members, and can I also ask Assembly members if they have any disclosable pecuniary interests in any specific items listed in today's agenda?
We've got teeth.
Yeah,
At the moment.
that's the only one. None, so I'll move on. So can we note the membership and chairing arrangements as agreed by the London Assembly at its annual meeting on the 10th of May 2024? Noted, thank you. And can I at that point just welcome our newer members of the Health Committee, Assembly Member Ahmed and Assembly Member Wilson, so Assembly Member Best, Assembly Member Boff and myself, previous members of this committee as well in its previous form, but I'd like to welcome our new members in particular, no offence to us sitting members in what generally tends to be a really positive committee looking at the health services in London and health outcomes for Londoners on a cross-party basis. So can we also now note the committee's terms of reference as agreed by the London Assembly at its annual meeting on the 10th of May 2024? Thank you. And can we note the standing delegations of authority to me as chair of the committee as agreed by the London Assembly on the 10th of May 2024?
Agreed.
Thank you. And can we confirm the minutes of the meeting held on the 13th of March 2024?
Agreed.
Thank you. Can we note the completed and closed outstanding actions arising from the previous meetings of the committee?
Noted.
And can we note the action taken under the delegated authority by the former chair in consultation with party group lead members to agree the Healthy Living for All report and the Gambling Related Harms in London report as well? Thank you. Quite a lot of business because it's been a while with the two different elections since we've met as a committee. But that brings us to today's main item, and I'd like to extend a warm welcome to our first panel of guests joining us to discuss dentistry in London. So we have Nikki Tavora, who is a dental surgeon and director of Brent, a lovely part of London, North West London Local Dental Committee Confederation. Natalie Bradley, who is a consultant in special care dentistry, King's College Hospital, and the chair of the British Dental Association Young Dentist Committee, and Elizabeth Fisher, who is a senior fellow at the Nuffield Trust. So I welcome you all to the committee today. So the first question is from myself, and it's to all panel members. So I think I'll start with Elizabeth, who's from my left. The British Dental Association has said that NHS dentistry faces an access crisis in England. Do you agree with your view, and what do you feel the main reasons are for this?
Apologies for the first hurdle. So yes, I think we, so just to put it in context, Nuffield Trust is an independent health and social care think tank, and we did a report on the state of NHS dentistry in England a couple of years ago. I won't necessarily be able to talk specifically about issues with London, but I think the issues that we found within our report, would have similarities to what might be happening in London. So, in our opinion, the issues in the NHS dental access, it's not a conspiracy theory, it's not something that's deliberately happened, it's basically been a function of policy neglect. And we would have said that if NHS dentistry had been a priority, we would have asked the government and the NHS to pay more attention and better approaches to the workforce, including the issues around the drift to the private sector and better use of other dental professionals. As well as improving the contract and the commissioning of dental services. I can go into some detail about the workforce for nationally. So the numbers of NHS dentists in England have barely grown in the last decade. So in 2022-23, the latest time we have data available for, there were just over 24,000 dentists that were carrying out some NHS activity. And that's not to say they're working full-time on NHS dentistry, and I'll come on to that in a minute as well. And that's only up 5% since 2010-2011. And that equates to about 43 dentists per 100,000 100,000 population, and each dentist has on average around 2,300 patients. Now, I actually looked this morning at the London figures, so if you think nationally it's 43 dentists in London, pan-London, it does quite well. There's 50 dentists per 100,000, but that ranges from 47 in North East London to 65 in North West London, so there's quite a big variation across the different ICBs. The drift to the private sector, so the structuring of the dental contract is very unique in the NHS, which allows a mix of the NHS and private work, so it allows this kind of drift to potentially happen. At the start of the 1990s, 90% of dentists generated 3/4 of their income from NHS work, and by the end of that decade, it dropped to 60% of dentists. And our analysis in the report that I talked about indicate that this has continued. So there's estimates of the proportion of time dentists spend on NHS dentistry, and in 2022-23 it was 70%, and that's down from 74.5% in 2010 and 2010-11. And actually in the London region it was down 68%, so that's a bigger drop in that for London. There's also, over time, been a shift in what the NHS treats. So there's been an increasing amount of NHS dentistry that covers less complex activity. And there's decreasing levels of activity for the kind of more complex treatment. So what this could suggest is that dentists are taking on NHS patients to do the initial assessments and the low complexity treatment, but not providing the more complex treatment under NHS care. We know that the private sector can offer higher pay and an environment that's preferred by many dentists. So the evidence that we have had shows that NHS dentists who spend more time on NHS dentistry tend to work longer hours, they take less annual leave, and the more time that dentists spend on NHS work, the lower their levels of motivation. Coming on to the skill mix, so you don't just have dentists, you have dental therapists, dental hygienists, dental nurses, there's quite a few of them. They're all registered with the General Dental Council, so there's certain standards that they have to adhere to practice. Where there have been issues in terms of workforce in other parts of the NHS, they've come to that challenge by diversifying the skill mix, so using those additional roles within NHS dentistry to provide some of the work that dentists have done. So the government's aspirations is to move towards that direction. So currently it's estimated that dental therapists and hygienists carry out 5% of NHS dental work, and the aspiration is by 2036-37 that goes up to 15%. However, if you look at the data from the General Dental Council, they're registered with them, so if you look at that registration data, you can see that there's a relatively slow move towards that kind of differentiated workforce. So overall, the non-dentist roles made up 17% of the GD register in March 2023, and in March 2018 they made up 15%, so there's been a really slow shift in that direction. So the limits in terms of NHS dentistry to be able to move that towards that kind of differentiated workforce is the size of the dental practices. So in our analysis, we found out that over 50% of all dental practices employ 4 or less people. And then there's also the kind of physical space in which dental practices practice on the high street, which can also sort of limit that. So in coming on to the contracting and commissioning, the 2006 contract reforms introduced the units of dental activity. So the units of dental activity, for a course of treatment, the more complex they are, the more UDAs are associated with them, and the UDAs are a measurement of payment to the NHS dentists. And that incentivised dentists to take on certain types of patients and avoid others, in particular those ones with high level of need. When that 2016 contract reform came along as well, the commissioning that accompanied it failed to deliver a kind of localised approach or the resources to use flexibilities to facilitate and incentivise change. The commissioning has also now been recently, I think in the last year or so, devolved to the integrated care boards, and there's a question like their predecessors whether they're going to have the expertise to robustly commission dental care for their populations, and this might be a bit more of a challenge going forward as well, because the ICBs currently have a requirement to reduce their running costs by 30%. And there's also a question about whether, given all the competing issues that ICBs have, whether they're going to make dentistry a priority in their local area. Nationally, funding for NHS dentistry has stalled, has not kept pace with inflation. So in 2022-23, funding was 2.6 billion, and I should say the funding is a combination of both patient charges and central funding. And that 2.6 billion represents a 20% drop in real terms when you adjust for population need as well. And the dysfunctions of the current contract also means that the hundreds of millions of that budget is not spent every year, and it's what we call clawback. It goes back into the system, but there's a kind of question about whether it's going back into the system in terms of dentistry or whether it's being used to shore up other NHS budgets. So ultimately, our conclusion was that this was down to a lack of policy focus. The NHS long-term plan in 2019 only had a few sort of mentions of NHS dentistry and oral health. The recent recovery plan from NHS England is a welcome shift in focus, but having been published in February this year, some people might say it's come a bit too late. And while there are some good measures on it to pull it back from the brink, it won't address the systemic issues and whether it will actually whether we get universal services again for NHS dentistry. And there's a question for you, I think, in terms of whether that recovery plan would address particular issues that you might see in London, particularly around sort of inequalities in access and outcome. And I just want to make a final point. I think the possible reason why dentistry might not have received the policy focus is that it's not seen as a life and death service. It's not like A&E. It's not like your hospitals. However, the policy inertia that we have seen around dentistry is now beginning to have an impact on other people's ability to access other care. So, for example, for care where people might become immunocompromised, such as cancer treatment or transplants, they will have to see a dentist prior to undertaking that, just to make sure there's no underlying issues with infections, and they need to have dental assessments. So delays in those dental assessments is now having an impact and delays for life-saving care. So, thank you.
Thank you. Natalie, anything from your perspective that hasn't been covered already in Elizabeth's remarks?
I think Elizabeth's done an excellent job of summing everything up, to be honest. But just a few things to add in terms of London-specific stats might be that in terms of looking specifically at access to dentistry in London, historically we thought it was quite good in terms of you have dental schools, teaching hospitals, but actually it's switched around in terms of it's got the worst access rate for children in terms of percentage of children accessing an NHS dentist, and there's a big disparity looking across the boroughs. That in some boroughs, such as Tower Hamlets, that's around 30-33%, whereas in other boroughs, like in Hounslow, it's 60%. So it's also a bit of a postcode lottery, and that's due to historic commissioning arrangements, but also in terms of people leaving the NHS as well. Anecdotally, as a clinician working in a tertiary care hospital, we are increasingly seeing people attending A&E with dental problems that would, if treated more upstream, would not have ended there. People being admitted with life-threatening sepsis from a dental infection. We've had to employ a full-time dentist within our department to see to the people who are due to have cardiac surgery in the hospital who can't have that cardiac surgery, as Elizabeth mentioned, until they have a dental check. And historically that was picked up by general services where people had their own dentist to access, and as a as a department, as a trust, we've had such an influx of people who don't have a dentist or are unable to access a dentist, and we've had to pick up that slack there. So I definitely think in terms of pan-country, there's an NHS access crisis, but specifically for London, there is definitely a crisis also.
Thank you. Just while you're on that, so things have gotten worse, if you like, since the pandemic as well. What would you attribute that to?
I think there's a number of, it's a bit of a perfect storm of several things coming together. So the pandemic has just highlighted the issues with the NHS contracts problem in terms of before dentists were able to get on by, they had stable lists of patients, so it actually was financially made sense to still remain in the NHS. They weren't burnt out. Their patients didn't have such a huge burden of disease that we are seeing post-pandemic, and that might be because they haven't seen a dentist for 3 years, and the cumulative effect of not having seen a dentist for so long, so they've got a large burden of treatment. We've also, in terms of workforce, had a few issues in terms of seeing few people coming over from the European Union who would be working. Had a pause in overseas dentists being able to sit the exam so they could be able to qualify to work. I think also the next generation of dentists coming out of dental school have had a number of years impacted for their clinical training, as they weren't able to clinically see their patients during COVID, and so maybe not have the confidence to see the patients at the same speed, and also the large amount of treatment needs that they have. So I think it certainly is a few things coming together that have created the problem that we're seeing now.
Again, turning to Nikita on the same themes.
So, first of all, I wanted to say thank you for making dentistry a priority so early on for the committee. I think carrying on from what my colleagues have said, access in London wasn't great pre-pandemic anyway. It has got worse post-pandemic, but we've never had great access for dentistry in London. So I think the question is, what sort of levels of access would you like to, would the government like to see? We do have a workforce. There is a problem with workforce staying on within the NHS. And following on from your question about what's changed post-pandemic, just the cost of staff wages in dental practices, the cost of materials, that has not kept in line with the increase in funding that's available for NHS dentistry, which is a massive issue for people providing that care. Dentistry is paid for by UDAs, but these are not a great sort of proxy for access, but they're often used as for looking at what access is being provided. And we know that patient charges are also an issue, both as a barrier to access and also operationally, as fluctuation of income to the NHS can cause budgetary issues. And this is seen on the ground level, because from one year to the next, it's very difficult for practices to sort of manage their budgets and know whether they're getting extra funding coming in for seeing extra patients and things like that. So we need to start collaborating with the different services and try to integrate our healthcare systems, because as we've said, it doesn't, yes, everyone thinks of dentistry as just teeth, but it actually impacts all of healthcare, and we do need to start collaborating more.
Thank you for that. And do you have anything further to add in terms of the decline in number of adults and children accessing NHS dentistry since the pandemic?
I think we don't have figures also for access for the private sector. So we've got figures for access for NHS dentistry. We don't have the figures for private dentistry. I think you've got several issues. You know, the results of the pandemic are the needs of the population have got that much higher. So you know, the average patient that you may have seen in practice might have been 1 or 2 appointments is now taking 3, 4 or 5 appointments up. So that is having a massive impact on how much care we can provide. Everyone who comes in needs that much more care as well, more complex treatment. And so I think those are the main issues.
Okay. Thank you. I'm going to now turn to Assembly Member Ahmed, who's going to ask the next couple of questions.
Thank you, Chair. Good afternoon, panel. My questions are specifically to Nikita and to Natalie, and Natalie, who is in another particularly lovely area of London, King's College, if that was the phrase, wasn't it, Chair? So my question is, why is London performing poorly in comparison to other regions of the country in terms of access to dentistry for both adults and children? Nikita, would you like to start?
So I think bottom line is there's just simply not enough commissioned activity. It's not that we don't have enough UDAs, but there's not enough service capacity. So access it's not targeted. It is a free-for-all. There is a bit of a postcode lottery. We have a larger migrant population who have different needs and generally higher needs as well. And different expectations and experiences of care. It's quite a highly mobile population, so it's quite difficult to track. It's a transient population, so they may access for some bits of treatment and then move on. And I think more needs to be done to understand why practices are under-delivering on their UDAs, because there is under-delivery on activity, and if they are, what we can actually do to help them. It's also never been a priority. Access has never been really prioritised by the government. You know, it's talked about, but it's never actually, the actions are sort of don't back up what's being done. I think also we've had successive governments have sort of allowed for a private dental market to flourish, and that also NHS dentistry can't keep up with the competitive private market. It's not as well paid, it's not rewarded, it's not the job satisfaction is not there. Morale within the NHS practices is, I've been involved in dentistry for over 30 years. I've never seen it so low. There's no registration anymore, so that's broken that sort of continuity of care between a patient and the practice. And it also prevents successful integration of services. And it seems to be that there seems to be a move towards episodic or care just for an urgent problem. And it's responsive rather than taking on a preventative approach. And I think dentistry is the only sort of prevention-based primary care service, and we're missing out on that opportunity of using that as as a vehicle to actually integrate healthcare as well.
Thank you. Natalie, did you want to add to that?
Just to add on some of the points Nikki's made about prevention, I think that a lot of the services that are provided in London are very reactive, as you say, in terms of treating the problem when it arises. But actually, a lot about access is you need to look at further upstream in terms of preventative measures and things like initiatives like supervised toothbrushing in schools, fluoride varnish prevention programs, and education in families. There's a big disparity in the different in different boroughs, particularly different populations. Like, for example, if you're a child who is of a Bangladeshi heritage, you're 1.5 times more likely to have to end up going to a hospital to have your teeth taken out. And actually, we can do more in terms of education about the importance of also attending a dentist as long as you're able to access one, as soon as the first tooth comes through. And actually, we as a profession should be integrated more within early year settings, school nurse appointments. Have you seen a dentist yet? Because what's happening is there's no access for in particular groups in London, and then suddenly they have a really terrible problem where they need to be admitted to hospital and have 20 teeth taken out under general anaesthetic, which then actually on that problem could completely on the whole be prevented. And in terms of programs like supervised toothbrushing, it's a no-brainer in terms of cost benefit. We're spending £9 million in London doing tooth extractions on children. If you're able to prevent that problem, that money could be spent elsewhere within dentistry and with healthcare.
Thank you. And you segued beautifully onto my next question, actually, and you touched on it as well, Nikita. Are there demographic groups who experience disproportionate barriers to accessing dental care in London, and what are the reasons for these disparities? And Natalie, if you could start, please.
Sure, of course. So I think certain populations don't understand or haven't got the educational messages through the importance of accessing a dentist. There's also, in terms of cultural barriers, in terms of language barriers, sensitivities. I've worked in various areas of London, including Camberwell, but I used to work in North East London, and you'd have my clinic, there'll be people coming in where you have Orthodox Jewish population, where actually if you don't understand, they're quite close-knit and penetrating and getting messages, any healthcare message, it is very tricky, and often they're coming in and you have families who have successive children who are that person, that my oldest had a general anaesthetic at that hospital to have the teeth out, and then you see the next one. It's quite demoralising as a clinician when you see that why are my messages not getting through? But I think a lot of it is working together with local populations. There are other people with disabilities will struggle to access services, and that could be physical as well as medical. People who are experiencing homelessness, for example, but it's a large range of people who have facing a lot of difficulties getting into practices. Simply a lot of it is to do with, I think, education.
I'm going to ask you something because I'm actually really shocked about what you've just said. So having a background in the health service and a very long time ago having worked in disease prevention, what you've just identified are issues that were happening decades ago about messages, about language. Why on earth has this not been resolved? Why are we still talking about this?
I think we were seeing some progress pre-pandemic in terms of the reduction, for example, in decay in children was levelling off, and I think a lot of that was to do with things like in terms of mass fluoridation of toothpaste, for example. Education around sugar and the Change for Life initiative. But I think we need to have a bigger voice as a profession on some of these wider healthcare messages. When you look at a lot of the sugar tax levy and all of the sugar initiatives, a lot of it is about reduction in childhood obesity and diabetes. But we're sitting here on the panel, we would be all screaming at the TV, when you see the adverts. Why is no one talking about tooth decay? So I think we as a profession kind of gets sidelined a lot in terms of, dentistry is just filling teeth. You have to pay for it. It's slightly different to the rest of healthcare. I do see the fact that now we're under ICB commissioning in terms of one umbrella, that could be a perfect opportunity to be able to integrate our messages within other healthcare settings and be seen as part of the team and the championing of importance of oral health. That it affects, not just your healthcare, your overall health in terms of things like your risk for diabetes and your heart disease, but also looking about how it impacts someone. If you have a child who has to take multiple days off school, how's that going to impact their education? Or how can they focus on their lessons if they're experiencing toothache?
Thank you. Nikita, did you want to add anything to the original question about various populations not being able to access care?
Yes. So I think the data that's been collected it's not routinely collected by the NHS BSA, but I think some of the data that's been collected by the GP survey does show that white British patients are the most successful in getting an appointment. And then this varies for other ethnic groups, with Gypsy or Irish traveller patients being the least likely to be able to get an appointment. I think a lot of, I agree with a lot of what Natalie has said. It's to do with education, awareness, and sending those messages out. And I think at the moment the LGC is running a survey with Health Watch in London to actually explore patients' attitudes towards NHS dentistry, and I think that just went out last week. So it'd be really interesting to see what the results of that survey are and what it shows with regards to specifically accessing the demographic data. So I think, I think the second part of your question is why are we still talking about this 10 years later?
Well, it's sadly, more than 10 years later, yes.
But I think there's a multitude of problems, and I think, the first thing we need to do is actually reiterating this, but it's that collaboration between different bodies to actually come together. It's not just a dentist problem, it's not just an ICB problem, it's just not, it's not one sector that is going to solve this. It is the collaboration of that, and I think the first step was the creation of the ICBs and the integration of healthcare. But what are we going to be doing with that? And how we need some accountability, we need some oversight of that process to ensure that we are meeting the needs of the patients.
Thank you. Chair, I wonder, Nikita referred to a survey that I presume there'll be results. I wonder if we as a committee could have the results of that when they come out.
Yeah, we can sort that out. Yeah.
Okay. Thank you very much. Thank you.
Thank you. Assembly Member Boff had a supplementary.
Ms. Bradley, you said that you wanted a kind of sort of parity for promoting good dental health along with other areas of good health that need to be promoted. Have you, has the Mayor of London or the Greater London Authority approached anyone to see if they can take on that messaging role? Because they're an organisation that understands the London population and understands the barriers that there are sometimes to approaching certain groups. And I wondered if you're familiar with any initiatives.
I think it's very locality based and service based in terms of the things that I've heard about going on in different areas of London. It's not, there isn't that parity because services aren't talking to each other and quite and sharing good practice. There are some organisations within dentistry that try to share good practice and pan-London initiatives. So they're managed clinical networks and local dental networks that try to take on some of these messages and share good practice and work out referral pathways and see to the needs of the local population. But still, I think it's all within, a lot of it's just within dentistry as a whole.
Yes.
Not.
I mean, the thing is that Greater London authorities, London-wide, have the ability to promote messages. And I just wondered if anyone was familiar with any initiatives that might have been taken. I'm drawing a blank here, aren't I?
I think there's things that happen locally, so, which might be directed by the council or the community dental setting or something like that. But it's that it almost needs somebody to orchestrate it London-wide to actually address the needs of the population. So, for example, in Brent, we have a higher incidence of oral cancer because of certain habits of certain ethnicities within the population. And that needs to be addressed. That's higher in Brent and Harrow than it may be in, I don't know, in Bromley or somewhere. So, but it needs somebody to that sort of oversight.
It's interesting that you brought up Brent, because it appears as that Ms. Bradley was just going on about the disparity that there is across London. What's going right in Lewisham that's going wrong in Brent? Because Lewisham seems to be, from the figures we've had presented to us, seem to be a good performing area in terms of, as good as you can get, in terms of dental referrals and treatment. Whereas Brent seems to be up there. It seems to be a specific problem in Brent that pushes it to the top of the or rather the bottom of the list in terms of dental access.
We've got a hugely migrant population in Brent, and it's a very transient population. It's also we do have a lot of migrants from Southeast Asian countries where there is an issue with betel nut chewing and tobacco chewing. So that is one of the reasons. We've got a lot of dentists in northwest London. I think that was one of the figures you quoted. We've got a higher proportion of dentists per capita in northwest London compared to other areas of London. So no, I think I don't know what the single answer is, but we need to look into it.
So there are figures available of access by borough. Is that something that we have?
We have got ward level access.
I wasn't aware that we'd had such a figure in our a briefing. So there are figures, and it would be great if you could share that with us in terms of which boroughs have got good access, which boroughs have got bad.
Could I just add as well that specifically in Lewisham and Southwark, those sorts of areas, we have 2 big dental schools. Yeah,
I know. I've availed myself I've availed myself of the opportunities of those, and it's very good to have a teaching hospital right there.
Exactly.
Very good. I think I've covered that now, Chair. Thank you very much. Thank you.
Thank you. Assembly Member Best.
Thank you. I was going to talk about the availability of community dental services. I think we've established there isn't sufficient capacity to meet the needs of the population in London. But I want to kind of drill down into what might meet that need and what are the barriers to meeting that need. I think, Elizabeth, you said earlier that there's 24,000 dentists across the UK. Do you have figures around where you think the numbers should be, and even better if you had them for London?
Simple answer is no. I think this is something we were talking about. What you need to do is you need to have a needs assessment first. If you don't know what your need is, then you don't know how many dentists you're going to need to service that need. Nationally, that's not done. I don't know how well that's done locally. So that would be the first step, that you'd need to do that.
So you think we don't even know what we're short of in the UK?
Nationally, I don't know.
Yeah.
Local areas might do it well. Some local areas might not do it very well. This is my point I made earlier about the kind of commissioning abilities of the ICBs now that they've got the new role in commissioning them. Some ICBs will do this well. They will do that kind of needs assessment. They'll make those judgments. But I think they have a real difficulty and real challenges at the moment to make dentistry a priority, like both Nikita and Natalie have talked about. To have that kind of integration with other healthcare services. The fact that they've got a lot of competing priorities within ICBs at the moment. You know, it's not just dentistry, it's in crisis. We know there's a lot of issues within the NHS at the moment. You know, when you've got oversight from NHS England, for example, around your A&E targets, as an integrated care board, are you going to focus on dentistry? So I think there's a lot of challenges for ICBs at the moment around dentistry and making it a priority.
Could I just come in there for a second? I think looking at the numbers of dentists should be a second to actually looking at the reasons why so many dentists have left the NHS. And I think the sticking point and the obvious thing for us as a profession that we've been talking about since 2006 is that there's no incentive. The contract is broken. There's no incentive to see people who actually need the need. You actually lose money as a practice or as an individual providing care for new patients. And so until the contract is reformed, there's no point looking at numbers of dentists, because if you train more dentists to go into a leaking bucket, you know, you're not fixing the problem.
And on reforms of the contract, because I think one of the concerns about reforming those is avoiding golden hellos, is there a way in which you think that we can make sure that actually that reform ensures it's to get the essential treatment, and especially those big jobs? There's probably a better word than that, but those that are most in need of those big jobs.
Well, I think with looking at the recovery plan, you know, you were given a new patient incentive for a patient who hasn't been for a couple of years, but we don't know how effective that's been in terms of upping the UDA values to a minimum amount. So it's only affected 4% of practices across London. So those initiatives are just quite weak, in my opinion. And what we need is, and what we've been calling for as a profession, is the whole reform of the contract. So we don't have a UDA, we don't have, we go back to, you know, what we would call patient capitation. Like if you go to your GP, the GP is paid for the number of patients they look after, with an incentive on top for those who have complex needs. And I think that boils down to a similar contract that would make it financially viable for people to remain in the NHS, to be able to spend the time that they want with the patients. Dentists want to provide good quality care. They want to treat the patients of most need. But at the moment, the system does not allow for that at all.
Can I just come in on the golden hellos and new patient premium? So golden hellos, I don't think there's very much evidence that they actually work. So we really don't know whether it's going to incentivise, you know, taking dentists where there's most need. I don't know whether they're actually from the National Recovery Plan, whether they're going to sort of impact London, whether, you know, there's going to be other areas within the country that's going to have a higher need. So I think there's certain criteria about whether you can apply for those golden hellos, and other parts of the country might trump London in terms of being able to use that as a mechanism for getting more NHS dentists. On the new patient, I keep on saying pupil, I don't know why, the new patient premium, I think the issue with that is that we just don't know whether it's going to incentivise dentists to do that. I think Manchester had trialled some of this there, but there's been kind of no evaluation of that, so we don't know how successful that was. We also don't know what kind of incentivisation they got, how much they were getting, and how relative that is to what the national plan is. So that might have been higher. So we just don't know whether that new patient premium is going to work and incentivise dentists. There's also sort of a risk to dentists, I think, because and correct me if I'm wrong, but my understanding is that an NHS dentist isn't going to know whether a patient hasn't seen a dentist in the last 2 years. So the only people that really hold that, because they won't have seen that patient before, the only organisation that holds that is the NHS Business Service Authority that do the reimbursements to dentists. So until the dentist actually submits that information, that they've seen this new patient and the NHS Business Service Authority check against their records, they might not be a new patient. So they've taken on this patient, but they're not actually new. So I think there's a real risk to dentists around that, and it's whether dentists will take that risk.
Can I add to that? So the new patient premium works that if the patient is new to the practice, they will get the new patient premium. So and this is one of the loopholes that patients are exploiting, is that they've been seen by a dentist down the road, and then they're coming to another dentist, and that they are getting the new patient premium, but they're not actually getting that routine care carried out or done, because you almost, as most dental practices won't want to see new patients because the level of treatment need will be that much higher, and there will be that much more work to do. So there are a lot of the practices that are not taking on new patients simply for that reason. I think also with regards to, the ICBs have been around for some time. And if we look at other areas of the country, they are actually having an impact on things like flexible commissioning and actually looking at addressing the needs of the local population. We're not seeing a lot of that in London. They've had very little impact in London. I'm hoping that we're getting a little bit more collaboration now. We are having regular meetings and they are taking place, but there haven't been many outcomes since the formation of the ICBs. We really welcome that move to bring commissioning back down to a local level as opposed to a national level, but it's not happening at the moment. So that flexible commissioning really needs to be a priority if we're talking about how to meet the dental needs of London, that does need to be a priority. Yeah, that's all I wanted to add. Thank you.
Okay, thanks.
Sorry, can I just add one more thing on the new patient premium as well? The premium is actually only time limited. I think it only goes up to March 25. Yeah. So what happens after that? And also you're bringing on new patients in terms of getting their initial treatment, but what happens then ongoing treatment? You're then taking them back into the dysfunctional NHS system that you've got. You see them once, but then they've lost their new patient status, but they've still got the issues that need to be addressed. So what happens then for them as well?
Okay. Moving on to some of the other, potential blockers, or to get your thoughts on that. So it seems like it's less about the numbers, more about the numbers of dentists moving into private until there's a needs assessment. How about space? Is there enough physical space for dentistry in London? And second to that, training routes. Are the training routes in London or nationally sufficient to meet population need?
I can start on that. In a word, no. There's not enough dentists. I think there are dentists being trained, but they don't want to stay within the National Health Service. So whereas 15, 20 years ago, a dentist graduated, they automatically went into vocational training or foundation training, which was 1 year in the NHS training. We're seeing a lot of dentists nowadays who are opting out of that, so they can graduate from dental school and move straight into private practice. They only have to do foundation training if they want to work on the NHS. And some dentists are just choosing not to do that. So we do need to take a step back to actually see, are we recruiting the right people into dentistry? Are we going about it the right way? We have had a survey with regards to asking the profession whether there should be a tie-in period for a dentist to work on the NHS, and there are very mixed results at the moment, so we're still waiting for a bit more data on that. So training pathways need to be addressed, and we need to, we are talking a lot about sort of financial incentives for keeping people in the NHS, but what about training incentives for keeping them in the NHS? These are kind of things that need to be explored and looked at.
Yeah, did anyone want to say anything more on that, but also to address the question as well around the actual physical space as well for dentistry within London?
To be honest, I'm not quite sure about the space. It's not a needs assessment that I've ever heard floated before in terms of physical space, which is quite interesting. Particularly in some dental. I used to work at Guy's Hospital, which is 6 floors of complete dental, and when we talk about space there, it's actually because it's a combined site. So it might be that in terms of centrally there may not be enough space, particularly for certain services, but maybe less so in suburban places. In terms of training needs, I think there is work that dental, our educational organisations are looking at how we are training our professionals, and looking at in terms of more flexible ways of training, incentivising people for certain backgrounds, upskilling our workforce from not just looking at new graduates and entering dentistry, but look at our existing workforce. Why can't we not train up our dental nurses and therapists if they want to upskill? But I think a lot of when you talk about numbers, everyone always looks about dentists, but you can't have a dental practice with a dentist in it. You need the rest of the profession as well, and they often get overlooked and forgotten. So maybe more information is needed about that specific London figures as well, because I wouldn't have those to hand.
So I don't know specifically about London, and what we do know is what I mentioned earlier, that nationally, sort of the size of the practices in terms of employment, the majority, so over 50% of practices within England have 4 or fewer people employed in those practices. So I can't imagine they're physically big spaces. And just following on from Natalie's point about kind of the development of the workforce, one of the things we called for in our report was that kind of increasing the skill mix, relying more on not just thinking about dentists, thinking about the whole workforce, thinking about your dental therapists, your dental hygienists. And one of the things that we called for was potentially looking at dentistry at scale. So in a large driver of developing the skill mix in general practice was being a shift towards primary care at scale, and the promotion of networks of GP practices, which you just don't get in dentistry, I think, at the moment. So that's one of the things we call for. But if that was to happen, what you'd also need is you'd need ICB support in the kind of change management, because that's not something I think you can just do in isolation, and I think there has to be concerted effort towards that.
Thanks. There was a question here on the impact of decreases of access to dentistry on oral health in adults and children, but I think that was covered to a degree earlier. So I just wanted to ask one more question around looking particularly at oral health in children. Obviously, when a child starts school, they'll get a registration form, and as part of that, they'll fill in their doctor's details. They won't fill in their dentist details. Is there any other way in which perhaps we capture how many children aren't registered at dentist, or in which that would be flagged and then dealt with? Or perhaps is this a way in which we could look forward at capturing children that don't have dentists at an as early a stage as may be possible?
Can I come in on that first? It'd be meaningless to a certain degree to capture kind of like who their dentist is, because a dentist is only legally obliged to, contractually obliged to provide the course of treatment that they start. You could go see a dentist tomorrow, and then you're not on a list, they don't have a list. So they see you tomorrow and they accept you tomorrow. You might want to go in 6 months' time. They've got every right to say no. And so even capturing that is sort of slightly meaningless.
Yeah. And this all comes back to contract reform.
Yeah.
Because if you're not contractually obliged to you're seeing a patient during a course of treatment, then there's no such thing as dental registration. In the same way that a GP, you're registered with a GP, you could go, and dentists don't talk to each other. The only people who hold that data is NHS BSA. So you could go to a dentist down the road, finish the course of treatment, then they don't have capacity to see you. Just go to another dentist down the road, and it promotes ad hoc, symptomatic engagement. And actually, if you want to make meaningful impacts, particularly in years which will really benefit a person in terms of early years, if you get someone into good toothbrushing habits, good dietary habits, they're not going to develop the need for invasive dental surgery. So it really, we need that investment, and that boils down to contract reform and a capitation-based system.
Sorry, Chair, just quickly. So you think the contract would have to be reformed in order to start flagging which children have never seen a dentist? Because I would suggest that even being registered to a dentist would be a good start to know that a child has at least perhaps been once, or has had parents that have taken an interest in their teeth in order to register them to the dentist, and that would be
registration doesn't
helpful.
Exist.
Or but you would have a dentist that you've gone seen if you could.
I think the question you're asking is, has the person has the child been to a dentist within a number of years? That was how you, but that just mean have they accessed the dental service? It doesn't mean they're currently under the care.
No, but I know what you're specifically saying, but there is almost a form of registration, i.e. when I go to the dentist to take my child, I have to sign all the forms, give them all my information. To that degree, I'm on their books. Does that make sense?
No, you're not, because there is that with the contract in 2006, registration was abolished. So if a patient comes to see me in the practice and I take them on for treatment, I do a checkup, my contractual obligation to that patient is to complete that course of treatment. So say, for example, they need to check up, a filling and a clean. Once I've done all of that treatment, that course of treatment is closed. I have no contractual obligation to see them again. So if the
What would you call it? What word would you use then for having a patient that you have
but
the
this
details
is the,
of?
But this is the problem. We've just got the details of that patient. That's it. We will send them a reminder for when their next checkup is due. But even when they come back, if my books are full, if I have no space to see them, I'm not contractually obliged to see them again. Now, most dentists don't work that way, and we do have that level of care and that duty of care, but contractually there's no obligation. So, and that is a fundamental flaw in this contract.
Yeah, I understand. Yeah. Okay.
Sorry, that's since 2006.
That's fair.
I know what you're trying to ask, though, and I think until the only other question you can ask is, like, similarly when you get your red book for your child, is there's a bit has your child had a checkup at a dentist, and it's a yes or a no, and that's the only way you can really capture that data, really.
The only other way you might be able to flag whether they've seen a dentist is the NHS Business Services Authority do produce statistics on the number of patients seen within the recommended recall intervals. So they do hold that level of data. They don't. I don't think they publish it. They only publish it at an aggregate level. So nationally and possibly at ICB level as well as the lowest, to give the proportion of the population who've been seen within recommended levels. They probably do hold the individual patient level data, but they wouldn't publish that, and I don't know whether they'd be able to give access to people on that in terms of flagging individuals.
Sorry, Chair, can I ask why contracts were abolished in 2006? Registration was abolished in 2006, sorry.
It came as part of the new contract. It was somebody's bright idea, and it came as part of the new contract. And we've had pilots being run in between on personal dental services and different contract models, with an element of capitation, with an element of registration, which generally tend to work better. People see a dentist more regularly. But yeah, we couldn't understand it as a profession back then either.
Can I also just come on to that in terms of the kind of valuations that I think have happened with that? They were so very narrowly focused on access as well, rather than outcomes. And I think actually some of these pilots drove down access, which was seen as a bad thing, so they weren't kind of taken on. But again, coming back to my original point as well, you know, these pilots were going on, but there wasn't the political will behind it, and the policy neglect that happened just didn't take them forward and didn't progress them.
Okay, thank you. That was very interesting. I think it's given us all food for thought. Assembly Member Wilson.
Thank you, Chair. Very, very interesting discussion so far. So thank you for your thoughts on the various subjects we've talked about. I didn't say this at the beginning because I don't think it really counts as declaring an interest as such, but tomorrow evening I've got a dentist appointment to replace, or hopefully replace a filling that fell out last week, but I had to have a private appointment. If I'd have waited for an NHS appointment, then probably the other fillings would have fallen out in the meantime as well. So that aside. Very interested to understand about this sort of decline of the proportion of NHS work relative to private work. And in your introductory remarks, Elizabeth, you said that the overall number of dentists performing at least some NHS work has increased a little bit, not a lot, but a little bit. But within that, obviously, there's been quite a significant shift in the proportion of work that they're actually doing with NHS. And reading through a lot of this paperwork and numbers, and I'm not sure if I got it from the briefing note here or from elsewhere, but I saw a statistic that I think about a third of dentists in total doing no NHS work at all. So keen to try and understand, you know, what's been driving that and how we can kind of reverse shift that. And I guess from the comments that have already come through, and particularly Natalie talking about the contract, it's largely the contract and saying the contract is broken, leaking bucket, those kind of analogies which I can completely understand make sense. So if you were to redesign the contract, what are the particular things that you would want to see in there that could reverse that shift and sort of re-incentivise a greater proportion of dentist work being spent, or time being spent on NHS work?
I think, firstly, appropriately remunerated system where your patients are registered with you and you are paid per your patient you're looked after, perhaps with patients who need a particular, who have more complex needs and more treatment needs, you are able to do that within the system that you're working. And so that then you get people don't go into dentistry to leave NHS, they don't go into train and with the intention necessarily to not, I'm never going to work in the NHS. It's I want to help people. I want to be able to get people out of pain. I want to be able to restore someone can smile again. But you need a sufficient time to be able to do that. And the NHS is not a charity. People should be properly remunerated for it. And as part of that, it might be incentives for if you are to remain in the NHS that you have proper career progression and rewards. As if you come in as freshly graduated and you're paid per unit of dental activity, you're paid exactly the same if someone's been working in NHS dentistry for 40 years, which you could see as a bit of someone who's got more skills, develop their skills over time. So I think it's a lot of it is how you're paid for your patient, and it's not about making loads of money, but we need to be able to run as business. Dental practices are individual businesses. So I think a lot of it is around being properly remunerated for the care that you're doing, but also career progression, being able to give back to your community in ways. So if you are a dental practice, a lot of what you're doing is your day-to-day face with your patients in your chair, but using your dental team to be able to go into your local school, go into your local care home, provide access for those vulnerable groups who would struggle or at the moment are excluded simply because there's so many barriers and too many people who are in the queue, and they always get pushed to the bottom of the queue. So I think those are some of the things that I would recommend. I think an early thing that we could push for that actually would come before contract reform is actually just ring fencing the dental budget. So as Elizabeth mentioned, if you don't perform your UDA target, or didn't you? Sorry, I think you mentioned it, Nikita, that it gets clawed back and absorbed into the wider net of healthcare, and often isn't spent in NHS dentistry. And in London, £12 million was clawed back last year from NHS dental contracts from underspend, and I'm pretty sure most of it didn't go back into NHS dentistry. And this is a real opportunity for ICBs to think about how could we use that money to go back into other projects and innovative solutions to increase access and improve the oral health of Londoners. In another role I hold, I'm a director of a dental charity, and we've a partnership with an ICB outside of London, where they've given us a large part of that clawback to provide access sessions using mobile dental units to people who are facing health inequalities. It's not an NHS contract, it's not a flexible commissioning, it's just an innovative problem-based solution where we've been able to negotiate with local ICB provider, the local ICB, what the local population needs and what we can do as a provider to increase access. Where in some services they've got a 3-year waiting list for children to get to a new dentist. So I think it's contract reform is a big ask, and it's something that we've been shouting about for a very long time. But even before that, there are things that could be seen as easy wins that could improve the access problems in London.
Thank you. Nikita, do you have something to add?
If we look back, the contract came in 2006. I think within a year or two, it was pretty much established that it wasn't working. But we're now in 2024, we're almost 20 years down the line, and there has been no contract reform. So I think everybody accepts that contract reform is needed, but that is a massive, massive piece of work before that comes to fruition. I think the things that we can do now are things like flexible commissioning. There are certain practices who can't produce or who can't fulfil their UDA requirement, but let's redistribute that money and use it back in NHS dentistry. There are certain practices who don't have enough UDAs to provide to their population base. I mean, if I look at the UDA allocation for a practice back in 2006, that was based on historic data of what the practice activity was in 2004-05. Today, that practice may still have the same level of activity, but the population around it has completely changed in almost 20 years. So we finally have a mechanism for flexibility, and we need to start making use of that. It's not a long-term solution, but it is at least some way going to fix the short-term problem. And at least we can start seeing more patients and create more access and actually start doing some more dentistry.
I agree with everything Nikita and Natalie have said. One of the additional things that we called for within our report was extending the recall intervals. So currently, the NICE clinical guidelines for being seen by a dentist is if there's no clinical issues. For adults, it's a 24-month period, and for children, it's a 12-month period. But currently, if you are lucky enough to have an NHS dentist, I think the norm that the public expects is around about 6 months in between checkups. So that's against the kind of national guidelines. So if you could extend those recall periods, then potentially that frees up additional capacity to see more patients. But the difficulty with that, the challenge that has for the dentist is, the public sees that as rationing, as, restricting access when actually it's not clinically indicated that it's needed. So I think that's a real big issue. And I think that's probably a national issue maybe rather than kind of local issues. And that would need sort of kind of national, public health campaign or, health information campaign about why you might not be seeing your dentist as often as you used to. So I think that's a kind of national problem that we kind of called for. The other thing I think has also previously been mentioned is the kind of investment in dental public health. I think it really needs, you know, using the flexible commissioning. So the flexible commissioning isn't about delivering the UDAs, it's maybe about delivering other services that will actually have a bigger impact in terms of, you know, outcome for your money, basically. So, yeah, that's what I'd add on to those.
Thank you. There is a question on here which I think mostly has been covered, asking about the impact of ICBs and so on, although as a sort of follow-up to the comments that have been made in relation to ICBs, of which I think all three of you have made comments. Is there a conflict between the kind of opportunity to include dentistry as part of a wider approach to health versus the kind of competing priorities of, you know, is it seen as a priority within that? So it's a kind of balance, and where would that balance be struck, and what's the best way to kind of maximise the opportunity without having the competing priority?
That's a very good point, and I think dentistry used to be, you know, a not very big fish in a pond, but I think now, in terms of, it was an election issue, and the impact on other services in terms of people turning up to their GPs, to pharmacies, to A&E, hospital admissions, I think it's becoming most of the ICBs are understanding that it should, you know, it is a small part of the health service in terms of the overall budget, but it's a service that needs to be prioritised in terms of the fact that it's been allowed to decline in the last couple of decades. But I think it will be very ICB specific. There are some ICBs that I've spoken to who are very engaged, who really understand dentistry and oral health, but there are some who don't. And you'd hope that since the ICB is established and taken over commissioning, they would have caught up. But it's a lot for the people within the ICB who might be moved across and merged across some other organisations, and now you're in charge of commissioning of dentistry and you don't know anything about dentistry. So I think it's really engaging. There are opportunities, and I think as a profession we have responsibilities to be able to engage with it. But I think it is the ICB understanding that actually there are cost savings to be made. You know, if you invest in a toothbrushing prevention programme in children in schools, then that £9 million that we're spending every year on hospital admissions for tooth extractions in children, you know, I'm not saying it's going to completely go, but it will be significantly reduced. So yeah, I think there's good opportunity with the right teams and the right engagement to understand the problem and think about solutions.
Yeah, I just reiterate, in the absence of the contract reform and how long the contract reform is going to take, I think for the Greater London Authority, the kind of level of influence that you would make, it's going to be, you know, it's going to be more effective at the ICB level. And one of the things in terms of preparation for today, I was asked about what action could be taken at mayor level, and I was thinking, you know, we did our national report, but actually in other work that we've done with the mayor's office, we helped develop and apply the 6 tests for major NHS reconfigurations within London. So that's to inform the mayor on his views about the reconfiguration and influence accordingly, and just wondering whether there's an opportunity to sort of develop a similar sort of framework for dentistry, possibly at the ICB level, to see, you know, whether they're having the kind of outcomes that they want, given that the ICBs and their new commissioning roles.
Okay, and then my final question is on the previous government's dental recovery plan. And again, Elizabeth, I think it was in your opening remarks, you said that you sort of welcome the focus, but sort of too little, too late, almost. So I guess in some ways it will be, you know, supplanted by whatever happens next under the new government. But are there particular things within that recovery plan that are welcome and will have a positive impact? And if so, yeah, how do we shout about that?
So I think the overall summary would be the measures seem sensible and they are welcome. I just think the real difficulty is that are they going to be enough individually and cumulatively to bring back universal dental services? And I think what we were saying in our report was there has to be an honest conversation about what can the government afford, basically. We pretty much think universal NHS dental services has possibly gone for good, and that we have to be honest about that, and that if it has gone for good, who do you target then to receive the scarce NHS care that you have? As I said before, the golden hellos, they're sort of relatively untested. The new patient premium is welcome again, but it is time limited, and the issues that I've talked about earlier. The preventative measures in school, again, I think the evidence is weighing on the positive side of that, but in the recovery plan they talked about delivering it to 3 to 5 year olds. So there's a question about where would you get the preschool children, how would you get them into that kind of preventative care? Who's going to do it? We have had a massive reduction in the amount of school nurses, for example. Schools themselves, teachers, they're increasingly being asked to do a lot more in the healthcare sphere. Is it right to be adding the burden onto them? Sorry, I just lost my train of thought. They were talking about providing fluoride treatments, preventive fluoride treatments for 1,650,000 children nationally. But if you look at actually the numbers of children who have seen a dentist in the last 12 months, only 50% of children have actually seen a dentist in the last 12 months. That still means there's 6 million children who've not seen a dentist in the last year. I mean, that's horrific. 165,000, fluoride treatments is just a drop in the ocean, basically. So, yeah, I think there's real challenges for NHS dentistry going forward.
Thank you. I'm conscious of time, and I know Assemblymember Boff has got a couple of questions I think he'd like to come in. So, just very quickly, if there's anything you'd like to add to that, or that might fit better with what Andrew's about to ask.
Can I just add to that? So coming back to, there's been a lot of questions being asked about school children. Not so long ago, there was a community dental service where every child was seen by a dentist in the school setting at least twice during their school life, and then referred to a dentist. So, all of these things, why can, and it doesn't have to be done by a dentist, that could be a therapist as well. So, looking at these kind of innovative ways of tackling these issues, that's what's needed. There's lots of solutions. You've got a willing profession, we have probably got enough numbers, but it's actually engaging the different arms to actually start working together to look at these issues.
Thank you. I'll move on to Assemblymember Boff.
What action would you like the new government to take to increase access to dentistry?
You guess what I'm going to say? Contract reform.
Contract reform. After all, they were the ones who brought it in 2006, and let's hope they can take it out. So.
Indeed. I think contract reform is a big piece of work, as we've mentioned, but there's been a lot of work of it upcoming which has just not been prioritised by successive governments. So I think that needs to be the core of what needs to be done in the long term. I think short to medium term, the easier solutions are ring fencing the dental budget, and coming back to the recovery plan, that was no new funding announced by the government. That was £200 million of dental underspend, which should be utilised in an effective manner, and that should be ICB led in terms of target driven, local needs based, where it needs to be, where most need is.
But scrap the UDAs, you're saying?
Get rid of UDAs.
Yeah, and yeah, good. And what action should the Mayor of London take to support improvements to dentistry and oral health in London, if anybody, that you haven't already suggested?
I think using his influence to try and influence the prioritising of contract reform by influencing the ICBs to be able to prioritise ring fencing the dental budget and not just absorbing it into the overall spend. I know he's prioritise things like school meals for every primary school child, and as part of that, any sort of supervised toothbrushing or prevention programme in schools is a no-brainer, in my opinion.
You say that the National Association of Head Teachers said that pledge for supervised toothbrushing in schools is not the response to solving the crisis. What would you have to say to them?
I think it's not current. The issue is you've got a current crisis and current disease that needs to be treated, and by the time, if we're ever going to catch up with that, you've then got a next generation of cohorts with the same MAP disease. So I think it's a part of the solution to help with a longer term plan in terms of improving the oral health of the nation.
Yeah. Some would say that we dump everything on teachers, and just so that we can have somebody to blame in the future. But thank you for that. Thank you for that reply. Thank you.
Can I add?
Yes, of course. I'm so sorry.
In terms of influencing the ICBs, is also influencing them to target the scarce resource as well. So we talked about children, but the other population groups as well, in terms of making sure that they've got that kind of needs assessment right, and that they're targeting the right people that should be.
Do you think there's an area that the Mayor could do in terms of promoting good public health messages about oral health? I mean, he's got the entire tube network, he's got all these, is that something they could do?
I mean, I think the main areas in London that we have an issue is children that we've talked about, but also elderly, vulnerable adult groups as well, who are not being targeted.
Am I right in saying that actually, just to finish this off, within time, actually, with all that we've said, actually, oral health in the population is getting better. Is that a correct thing to say? And that we see that because generally speaking, the condition of older people's teeth is not as good as the younger generation.
It was getting better. We've seen a decline post-COVID.
Post-COVID. Yeah, everything happens post-COVID.
Inequalities within groups. You'll have certain people who are able to pay for a private dentist and their oral health and prioritise their oral health, but the disparity between population groups is widening.
And I feel like it's like Christmas because I've already got some minutes. Is it fair, in the private practice, private dentistry, are they suffering similar pressures?
No. I
So
wouldn't know, 'cause I
there's
don't work
enough
private.
dentists, there's enough to cope with it.
Because you're getting, in the private sector, you're getting remunerated for the work that you do. In NHS, there are certain treatments that we provide that I'm actually saying to the patient, here's £50, come and have your treatment done with me. I'm paying the patient for the privilege of providing them with that treatment. So you don't have the same...
Anecdotally, somebody else, I think Assembly Member Ahmed used to, one of us used you used an anecdote earlier. So I'm on a waiting list for an implant, fully paid for. I'm going to pay for it. And that doesn't, to me, indicate that the dentistry is... there's enough staff, or if private dentistry is turning people away.
I think it depends.
But you say that you're saying it's fine. I believe the expert rather than my own experience.
I think it depends where you are.
Yeah.
There are certain challenges that private practitioners are facing. Yes, they can, spend as much time as they want with the patient and appropriately charge for whatever they want to charge, but their costs of running the practice is going up. Their recruitment of dental nurses is a particular challenge. I know anecdotally from speaking to my colleagues, it can be quite tricky. Recruitment of some dentists in some areas, it can be more challenging as well because there is, if you're a dentist and you want to work as an associate now, it's a good market. You can choose where you want to work and people are agreeing.
I think that's interesting. That is very interesting. So the contract's the thing that needs to change. Thank you very much.
Very quickly, promise everyone the best.
Sorry, I'm just going to try for it. Nikita, you obviously provide NHS services.
Yes.
Is there anything that should be retained, or essentially is it goodwill of people like you? doing that now?
Yeah.
It's essentially goodwill. There isn't something that you would look at and say that's...
Historically, there was, NHS could compete with the private sector because there were additional benefits that were offered for, in terms of pension and things like that. But now it's such a wide gap between NHS practice and private practice. I think Natalie mentions about private practices suffering as well. But from an NHS practice, we're competing with those same bank of dental nurses, but we can't afford the higher wages in an NHS practice that the private sector can offer because they're charging higher fees and things like that. So I think what, from an LDC point of view, what we'd like to see as a response from the Mayor is things like, championing the establishment of centres for dental development, which has already started, where we actually have focused centres which will provide NHS care, and purely just NHS care, as well as training dentists and therapists and nurses, etc. So it's almost providing a training centre, which means that we're upskilling our workforce as well as providing NHS treatment. And also accountability from ICB's councils to actually say, okay, how are we going to tackle these issues? What are we going to do? How do we work together to look at these and bringing... It needs somebody to orchestrate it, somebody to coordinate it, to actually say, this is our focus, let's bring everyone together.
Thank you. And Natalie, can I just ask for a quick clarification, because I think it will form part of our report, Chairs. When you've talked in support of supervised toothbrushing a few times, in your head, do you envision that being a dental hygienist coming into schools? Are you picturing teachers?
I'm picturing it being supported by dental professionals.
Okay.
As you say, you can't just... teachers have got enough on their plate.
Thank you.
But okay. It doesn't have to be a dentist, though. It could be.
Thanks. And this, hopefully, really quickly, if we were looking at international comparators when we put together our report, is there anywhere that we should look?
I mean, we didn't look at it in terms of outcomes in our report. The only thing we looked at internationally was the number of dentists per capita, and the countries we looked at were Germany, France and Italy, and ultimately they just generally had more dentists. But the international comparisons are quite difficult to do because of the way their systems are set up in terms of how they provide the services, how it's all funded. So there's a challenge there in terms of comparisons and learning from those areas.
Thank you. And sorry, very quickly, Assemblymember Ahmed.
Thank you, Chair. Just going back to supervised toothbrushing, and Assemblymember Boff, I thought it was actually mothers who got blamed for everything. I know that because I am one. So Assemblymember Boff's talked about head teachers. I'm actually interested in what dentists think about supervised toothbrushing, and because they're the ones that have to deal with the not toothbrushing. Now, I remember when I was at school a very, very long time ago, but, we had a lesson about teeth and then about how to brush correctly, and the girl next to me said, oh, I've been doing it wrong. And, she would have carried on doing it wrong all of her life if we hadn't had that lesson. So I do wonder, what do dentists think about supervised brushing?
I mean, if you, thumbs up. There's lots of really good evidence out there that in terms of the impact it has. So I think that speaks to a lot of dentists in terms of looking at, is the intervention cost effective and worth my time as a professional? And I think actually a lot of, in my other hat as well, with my dental charity hat on, we have a voluntary based programme where we have volunteers that go into early year settings and provide oral health education, and all the feedback from the volunteers, and they are a mixture of dentists, dental nurses, just people interested in teeth who've had the right training, is actually they really enjoy it. It's really fun and it's really rewarding. Are you seeing that you're helping that that, you know, the class in front of you take those messages on for the rest of their careers. And actually, it can be really helpful and rewarding as a professional, because it gets you out of your dental practice and you're able to give back to your local community. So, yeah, thumbs up, I think.
Thank you very much. Thank you, Chair.
Thank you. At that point, I'd like to just thank our guests for attending and their useful insights into this important issue and their answers to our questions. We will now take a 10-minute adjournment before we come to our second panel of guests. Thank you.
Thank you. Thank you, guys. All right.
Welcome back to the Health Committee and welcome to our second panel of guests. So we have Martin McRae, MBE, who is the Director for Improvement, Transformation and Partnership at NHS England London, Will Huxter, who is the Regional Director of Specialised Commissioning, NHS England London, and Jeremy Wallman, who is the Head of Primary Care Commissioning, Dentistry, Optometry and Pharmacy at NHS North East London. So welcome all to the panel. The first question to the panel will be from myself. Just reflecting on the British Dental Association and their view that the NHS dentistry faces an access crisis in both London and across England. Just want to hear your thoughts on that statement, maybe starting from Martin.
I might hand over to Mr. Huxter, actually, to lead on that. But as a starting point, when we talk about access, that's a really important point. At the time, you need preventative checkups or you need treatment. But dental health starts well before you need a dentist. And I think it's really important to lay out some of the public health issues that underlie dental need in the city.
Will?
Thanks. Really important question, and certainly it's one that comes up from the public on a really regular basis. Are very aware of that. I suppose it's just worth setting some of that more in context around, obviously, where we want to get to is we do more in the prevention space. We do more to promote good oral health, because the level of dental access which is required for children and for adults is a reflection of our having not had the success that we'd like to in terms of early prevention and good oral health. And we know, if you look across London, I'm sure this will be subject of the committee's questions in some part, we know based on ethnicity, on income, on demographics, there's real variations in uptake, but also in dental ill health. And that's a reflection of a whole range of different things. There are quite a lot of different barriers to access which are generic, including, of course, for adults, issues around charging for services. So we can really happy to talk about the situation in London. What we'll describe is not where we'd like to be, however, relatively to other parts of the country, a stronger position in London in terms of access than elsewhere. But Jeremy, do you want to talk to a bit more of the detail?
Yeah, absolutely. So I think just to follow on from what Will said, the NHS dentistry in terms of access to it, is a challenge. I don't think there's any question about that. However, obviously our concern has been the delivery of it in London. And like Will said, relative to other parts of the country, access to NHS dentistry in London is far better. And that's been borne out by the contract delivery that's been achieved this year across London. We've just come out of the previous contracting year. So a lot of what's come about in the last year or so is a sort of a return to pre-pandemic levels of activity, which is sort of a minimum, if you like. So it gets us back to delivery that was there pre-pandemic. I think in terms of it is scattered around in terms of you will find access easier and better in some parts of London than others. But I think there's a key fundamental, and it's probably unique to London, in terms of the fact that as you probably know, there is no registration as far as dental practices are concerned. And patients in London quite often access dentistry all over London because they can. It's not limited to catchment, it's not limited to residency. That aspect is universal. And also we're a net importer. And what I mean by that is there are vast numbers of people who access dentistry in London that don't live in London for all sorts of reasons. But I think really, rather than going into masses of detail, to say that the position in London now, and we saw near 95% contract delivery last year, which takes us back beyond where we were pre-pandemic. So it's getting back to where we were. I think the challenge is actually to expand that more. And actually, I think one of the key challenges is access is available, but people don't necessarily take it up. And there are a whole host of reasons why that doesn't happen. Some of that's around communication, and some of that will be absolutely down to pure economics. because obviously it's chargeable, and unless you're exempt, you are liable to those patient charges. And as you know, in terms of the bandings, if you fall into a band 3, then we're looking at £300. So for most people, that's prohibitive. And I think just to build on that, that's why we have a universal urgent care delivery in London. So that was really born out of what we put in place during the pandemic, because obviously that was all that was available because dentistry was effectively closed. We now have a 24/7 triage delivery across London, and also access to urgent dental care for anybody who resides in London. Because obviously if people are in pain, they need to be got out of pain, and we have a delivery for that. And it's also an acknowledgement that in many cases that's how people choose to access dentistry. So if you say to someone actually about going regularly, a lot of people aren't interested in going regularly. They want it when they need it. So in a way, as commissioners, we have to be responsive to that. So urgent care delivery exists in London across the piece, both in and out of hours. And we have a triage service via 111 that anyone in London can access if they're in pain.
Okay. Just on that, because you've mentioned charging for services, so is there an issue here where at the sort of regular routine appointments and checkups, because they're not taking place as such, it is leading to more emergency care needing to be provided, and what does that mean in terms of cost to the NHS?
I think there's probably something in that, in terms of people going routinely. And I mean, we've seen sort of the legacy of the pandemic has been a really, really stark reminder of that. So the decay rates have definitely increased, and that's as a result of probably people not accessing dentistry for the best part of a couple of years. So treatment need has gone up, but just in general. So you know, people, even if they go regularly, may fall into one of the other charging bands, because obviously it depends on what's needed. But I think there's definitely been an increase in the acuity around what one dentist effectively said to me. The best way I can describe it is pre-pandemic, someone might have needed 1 filling. Now they need 3 or 4. So effectively, that means treatment time takes longer as well. So if that's a recurring theme, you can see why the capacity has been challenged.
Yeah. So you seem to suggest that access in London has improved, and how would you say that compares to the rest of the country?
Well, in terms of if you look at the levels of dentistry delivered in London pre-pandemic, so this is across the piece, London is the closest to that out of any other region in the country.
So London has reached its pre-pandemic level before anyone anywhere else, basically.
Yes.
Okay, Martin.
So two reflections. I think it's really important to acknowledge in saying that, and we're pleased that we're providing that level of service, but we probably all know someone who has tried to get a dentist appointment under the NHS and has not been able to find a dentist to see them. And that's not where we want to be. And the second thing is that just because we're better than elsewhere in the country doesn't mean that we have access levels at the level we want. So back to Jeremy's point about people accessing emergency care, yes, we'll provide the care that people are demanding, but we'd rather that they were looking after their oral health in such a way that they didn't need 1, 2, 3, 4 fillings and leave it till the last minute to have to go to an urgent care practitioner to do that. We'd rather the regular yearly checkup that's advised. We'd rather people looked after, stop smoking, looked after their diet, all the things that we know lead to good oral health.
Okay.
I want to acknowledge that it is an issue, one that we are trying to address. We're doing relatively well, but relative to a poor position.
Sure. Thank you. I'm going to move on to Assembly Member Wilson.
Thank you. And it's encouraging to hear actually that London is effectively leading the way in getting back to where we were pre-pandemic, so that's to be welcomed. But obviously within London, there's a huge range of disparity, and we've got a table of figures for both adult and children access broken down borough by borough. Interested to hear if you have any particular thoughts why certain boroughs are doing better than others, and in particular, based on these figures, what's been going really, really well in Hounslow, and what can other boroughs learn from that to try and match that?
I mean, I think the sort of comparison between boroughs in a way is not overly helpful, only in as much as when the contract first came into being in 2006, most of what's in place was what effectively was put in place then. So that's on the basis of the number of NHS providers, contracts and all the rest of it. And there may well have been a higher proportion of delivery of NHS dentistry, for argument's sake, in Hounslow back then. And that's obviously, you know, that's filtered through over the years. So it will be relative to the level of dentistry that was provided in that particular patch when this contract came into being in 2006, which seems like a long time ago, and it is. So, but that won't have changed massively. So the levels of access that were there have generally been maintained. And you've seen, and I mean, obviously there's some peaks and troughs throughout the years, but I would imagine if you go back to when these contracts were put in place in 2006, that graph would look pretty similar to what it does now.
There are particular things that could be picked up on and learnt from so that other boroughs could then replicate that success?
It's simply around the capacity that's there. So if you were to say, well, actually, how does I don't know, for argument's sake, someone at the other end of the scale, I'm just going to use like somewhere like Kingston, replicate what it does in Hounslow. In most cases, it would be, well, actually increase the number of NHS dental practices that it has in that particular patch, because what you'll find, and particularly North West London has the biggest proportion of dental practices anyway. So it's probably something as simple as that. But obviously, the resourcing, if you like, of new NHS practices, they require procuring, and that's obviously a significant amount of resource to do that. So if you were to bring everyone up to a similar level, it all comes down to the resources available to do that.
Okay, the next question I have then, obviously the briefing paper that we've had sort of talks about the overall budget in real terms effectively being cut, but at the same time it talks about underspends and clawback and as an issue. What is the NHS in London looking to do to try and address that and make sure that money, if it is effectively lost, how can that be kind of withheld within dentistry more widely, and what would you look to prioritise that rather than just losing it back into the general kind of NHS pot?
I mean, maybe if I say something overall and then Jeremy can comment more on the detail. I think one of the challenges is the way in which activity is looked at on an annual basis as a contractual arrangements about the basis on which we commission, and then non-recurrently, if that's not all used in a particular contract, we take that money back. What we don't have is a forward arrangement for X years, so it's quite hard to use that money creatively if you're only getting it back on a non-recurrent basis late in the financial year. So one of the things that would help in the future, and this is all managed by a national contract which is not determined in London, is more flexibility around longer term arrangements for looking at alternative things would help. Jeremy?
Yeah, it's a good question because and I think, and again, it's people's understanding about how that works. So effectively, commissioners ultimately have a recurrent dental budget, which is effectively ring-fenced. So it has to be spent on dentistry. And obviously there's quite a bit of attention on that. But as Will says, you go through a year if a provider has under-delivered. And I will say this, GDPs are the only set of primary care practitioners that have money taken off them if they don't deliver on the contract that they have in front of them, that residual amount under 96% gets effectively what you call clawed back, but it's effectively done a non-recurrent resource, and that money then effectively is only available non-recurrently. I think to say in terms of the pack you've got there, so you will see reference to the clawback. That figure that you've got there is pretty much back to the levels we saw before the pandemic. So across London, I think with the inflation it was, because I seem to recall that similar sort of figure most years between the 16 and the 20 million coming back. So again, I would expect to see that come down. So it's good because actually it means more and more of the dentistry that's being commissioned is actually being delivered. rather than us effectively losing that. But the actual recurrent budget is effectively protected. That is ring-fenced. So it rolls on. So if it was the budget this year, you get the same again next year.
Just one final sort of question or comment then. The panel, I was going to say this morning, it wasn't this morning, but the earlier panel, a lot of comments suggesting that sort of more general contract reform is something that is wanted from the sort of practitioner's point of view and would help with kind of access and availability and so on. Is that a view that you share?
I suppose the best way to sort of come back to that is obviously we work within the confines of the contract that is set down in regulation. So, you know, that's our role as a commissioner. Like any contract, given the life of this one, you would hope that always they are reviewed, and they are, in most cases, are always going to be at some point due for reform. I think the bit we work, I think, as flexibly as we can within the confines of that. I think the bit for us, if we were to say, well, what would you like to be any different? I would like to see prevention rewarded properly within a contract, because actually I think from a GDP point of view, that must be one of the most frustrating aspects, because it's not, you know, obviously there's a level of oral health advice that they provide which is implicit in anything that they do with the patients that they have, but being able to have the time to provide that level of oral health promotion advice and really feel that they are actually getting a preventative message across, that would be ideal. That would be the, you know, if you were going to say, well, what change would you like to see, that would be the ideal one.
Yeah, thank you. So, without having heard the evidence given, your précis of it, we wouldn't disagree with. The contract is the important vehicle for which to deliver this, and it goes back to your previous questions about why is there such a disparity between boroughs, because contractually that's where we landed when the last contract was set. There are two big national contracts set outside of our control. We don't have any levers of control on it. We're not involved in it, which is the dental contract and the GP contract. And if you think about it, dentistry and general practice are the most community-based services you can imagine within health. And yet, they are national contracts set nationally to meet a national agenda. That's why we're stuck with a set of accounting rules that mean if we don't use the money within year, it's lost because it goes back into the national pot. So I'm not an expert on the contract and how it should be, but there must be scope to allow greater and more flexible investment in services to meet community need. And if there's a plea from us, it would be to echo that, so that whether you live in Hounslow or Bromley, you get the same level of access and the same quality of care which you between the two, and we don't have that flexibility within the contract rules that exist.
Thank you. I'm going to turn to Assembly Member Boff.
But before we move on to my questions, just to what you were saying earlier, there is a diversity across the ICB. But there is a consistent low uptake of NHS dentistry from ethnic minorities. Is that something that the contract sets as a target or an aspiration?
No, not specifically, no. Right. But it's something, obviously, you can see that in the data. And there are a number of reasons why. Some of it's just down to basics in terms of communication about what's available. But again, that's something that has to be, I think, on a recurring basis. We've got a very diverse population in London. People, obviously, clearly, where English is not their first language, and also it's perceptions, particularly within ethnic minorities, around the fact that there's an assumption that anything health-related has to be paid for. And obviously, if you've got children, dentistry is free. It's free. It's freely available for them. But again, it's that sort of, so it's constant messaging. So one of the a positive aspect, I would say, of delegation and ICBs is that ability maybe to drill down at a bit more of a local level and actually do some of that work locally to make it clear to people what's available. Because actually in some cases the take-up is purely down to not knowing.
To talk about that delegation that you refer to, I mean, what has been the impact of that delegation since 2006? Because you seem to indicate that not much has changed.
So I think just to clarify, 2006 was when the new contract came into being. Delegation of dental, optom and pharmacy commissioning took place last year.
Yeah.
So it's now with the ICBs as opposed to with NHS England. We have a hub position. But going back to what Martin just said, regardless of delegation, the mechanisms around contracts, none of that's changed. So ICBs will have the same challenges to deal with as any other NHS region did previously in terms of the constraints of the contract.
Have you seen any changes since that then? I mean, you tend to change things because you want them to improve.
Yes. So what I would say is it's a continuation, because I would always advocate in terms of London, there was a level of transformation that's gone on in London in the last 10 years that we can demonstrate quite vociferously. I think where you've got now is you've got individual ICBs have their own allocation, which is based on obviously the level of dentistry that goes on within their ICB. And what I have seen is a continuation of what was going on in NHS England in terms of where we can put additional resource into NHS dentistry, whether it be, you know, on a part year or a non-recurrent basis, to actually make sure that access is as widely available as possible. Now, last year, from after following our move across, all of the ICBs in London invested a considerable amount, varying amounts across ICBs, so that basically we had a position where by the end of the year, practitioners weren't in a position where they were having to say, look, I've run out of UDAs, I'm having to close my book. We've been able to maintain and in some respects expand the access. So if I'd said, has anything changed, I would have said no, because actually that would have occurred whether we were at NHS England, London region, or delegation. That would have occurred anyway.
So how long do you think we're going to have to wait to see the efficacy of changing the delegation?
I don't know. It's an honest question to that. I think it's
a very good answer.
Yeah.
There's more guests would say that, actually.
Yeah. No, I mean, in fairness, delegation is we're a year in, and obviously ICBs have a whole host of issues to grapple with, but I think what you will see is you'll start to see transformation at an ICB level starting to sort of manifest itself.
How many ICBs are there
in London?
Yeah,
5.
So they're quite chunky.
So they're about 2 million population size, 3 in the north of the Thames and 2 in the south, between 5 and 8 local boroughs, depending on which one you're talking about. The only thing I'd add, Assemblymember Voth, to your question, you do want change. It hasn't come yet, but ICBs are set up to in law and statute to meet the health needs of their population. And the difference between that and NHS England is we are the performance manager and regulator of the NHS. So we have a different perspective. And we'd hope, though I'd agree with Jeremy, I can't say when, that they'd start to say, well, this bit of our geography needs this level of communication or this level of service, and that will change. And they can change things at the margins. I've explained about the contract, but they can change things at the margins, and you'd hope, and we see it in other work of ICBs, because they've been established now for 2 years overall, the delegation happened last year, where they're starting to be far more locally specific about their healthcare provision. And we saw that first off in vaccine delivery, where, we started, and I remember coming to a committee previously explaining about how we took a one-size-fits-all for vaccine delivery, and what that meant was certain parts of London got a really poor uptake of vaccine. And when you start to bring it down and say, right, what does this estate need, this neighbourhood, this community need, then you start to see the benefits of providing services in a different way. We're not seeing it in dentistry yet, though.
You mentioned this as legal response. Oh, sorry, Mr. Huntston.
Yeah, I was just going to say that I think one of the other opportunities that delegation offers is that some of the populations who have least good uptake of dental services have least good uptake of other services as well. So there's something about a joined-up approach, think about the population and its entirety of needs that the ICBs have now got responsibility for, that may mean there's a positive impact in terms of not just dental but also accessing other services as well. So there's a confidence and trust point to be got across and supported for with the local population.
And just to touch on it, really, I suppose it's we've got sort of two worlds coming together a little bit, and I think it's just to understand the sort of complexity associated with dentistry being delegated. And so it's probably a natural analogy to sort of think, well, that's similar to general practice. But the one key bit being that there is no registration. So therefore, if you're looking at it from a neighbourhood, a place-based scenario, that dental practice located in Hounslow, for argument's sake, can see anybody within that practice from within England. So even though the ICB is paying via its contract with that individual.
Would registration help?
Whether it would help or not, I think the only counter to that, if you're paying for registration, you also need to make provision for treatment as well. So if you were to add registration into the current sort of setup, that would require additional resource. So whether it would help or not, it would help in as much as from an ICB point of view, they could say, this is for our residents registered in our borough, place, whatever. But what you've got at the moment is a contract that actually doesn't fit in that respect, because it's available to all who wish to access it and are eligible to access it. So the analogy would be a dentist in Hounslow sees all of its patients from Leeds. And I know that's a bit of an extreme thing, but they would be perfectly within their rights to do that. And the ICB that they are resident in would still have to pay them their contract. Right. So it's just to get that is the reality.
Yeah, we talked about the legal responsibility of ICBs to target their services to the local population. Do they actually have the powers to do so?
So they have more levers for change than we would at a regional level. The relationships they hold with local authorities and the directors of public health particularly is a really important one when it comes to dental health. We don't hold those relationships. We have a regional relationship with the public health team, not a local one. So issues like that, they don't have, and under the current contract, the ability to grow at the pace they want to, the dental provision. It's not just about the contract, but it's also about the supply of the workforce in there. We haven't come on to workforce yet, but workforce development's a really important part of this. We need to make sure there are enough dental practitioners, both the dentists, dental nurses and dental hygienists, to make sure it serves the population. They have some ability to change things which we don't, because they are more local, but they don't have the, using your words, the power to instigate the radical change that may be needed to really do a step change in access.
Sounds a bit unfair, giving them a legal responsibility and not the powers to do it.
That's another debate.
Yeah. Okay. Thank you, Chair.
Huge devolution in the NHS debate, I think. Just wanted to use my chair's privilege to talk about to ask about ICBs as well, just from your perspective, Jeremy, because the first panel we had actually did talk about the difficulties with the fact that the ICBs obviously are looking at a population health within their areas and the competing priorities where you do have sometimes NHS England giving sort of steer or directives on, you focus on cardiovascular disease, focus on diabetes or particular issues, A&E targets, and waiting times at hospitals. Where does dentistry, or what have you seen in terms of the impact of dentistry within conversations at the top level at ICBs?
I wonder if it's just worth saying a little bit about we'll build on the devolution point and then bring Jeremy in.
Yeah.
I think one of the really important things when we talked with the 5 ICBs before the Services Commission responsibilities were delegated was how we would organise things. And there was a universal agreement among all the ICBs having Jeremy and his team as a London-wide resource with that expertise, that knowledge across London and the ability to look at comparison and so on and support them in making their commission decisions was really important. So I'm really pleased that that expertise has been held together in one place. So while Jeremy and the team are hosted in North East London ICB, they're providing a service to the whole of London. I think that's a real advantage we've got because partly of the flows about where people go, but also that we can pick up on trends and look more systematically across London. Jeremy?
Yes, I think it's been a step change. So I think we've moved from a scenario where I've just said from my perspective and also my teams, we were semi-autonomous in as much as we were delivering for the whole of London. And from a pathway point of view, we need to maintain that. Because of the way London is unique in that respect. And I'll use an example. We have a universal paediatric pathway across London, and disaggregation potentially puts things like that at risk. Because an ICB might say, no, we're not doing that anymore. You know, we're going to do this and try and sort of do it do it differently, more locally, and all the rest of it. So I think, like any reorganisation in the NHS, and we've been through a few, the fundamental is to try and not, with any of these sorts of things, maintain a safe landing so that things aren't disrupted unnecessarily. So I would say in terms of the delegation that's occurred, we had exactly that. There was a well thought out process in terms of us moving across. It was a big change for the people involved because obviously we were splitting away from an organisation that had been part of for 10 years. But the fundamental was that we were able to maintain relationships with the profession locally to instil that confidence. And I think a year in, obviously, you do need to start to see your relationships develop between ICBs and the dental profession locally, because that's the direction we're going in. That's what. And I think our role is to sort of oversee that. And in some respects, we've moved to a more of an advisory position now, because ultimately the responsibility is with the ICBs. They have their allocation. They have the responsibility now. What we're there to do, in a way, I think, is to guide them a little bit. And actually, in some cases, you know, in the extreme, say, you can't do that. Or actually, have you thought about this? So relationships are everything for us. I would say there is a fundamentally very good working relationship with the GDPs in London. We've worked extremely hard with the LDCs. We have a good working relationship with them. Don't always agree, but actually it's a professional working relationship. And coming back to a bit Martin said earlier on, not that you would ever wish a pandemic on anyone, but the relationship enhanced hugely during the pandemic to a point where I think there was genuine, real professional respect between both parties, because we were all working towards one aim, which was actually to try and provide services for patients in very difficult circumstances, and that extends across to the pharmacies as well. So in terms of the move across the ICBs, it's there. We can't avoid it. So what we've got to try and do is build on the situation that we had in London, and we were starting at a higher bar in London. So I would say that the ICBs haven't got some of the problems that some of the counterparts in other parts of the country have got to deal with in terms of picking up, particularly with dentistry, at a very low point. I think we're higher up, so actually it puts us in a better position.
Thank you. I'm going to turn to Assembly Member Best.
Thank you. I'm going to talk a little bit about the dentistry recovery plan. What has been implemented, if anything, from the dentistry recovery plan?
So, dental recovery plan was launched, about February time. So there were a number of key planks to it. There were a number in terms of the contract. One was an increase to the minimum value of a UDA. These are the units of dental activity that general practice work to, so contract currency. So that was uplifted to a minimum of £28. So that was implemented because that was expected, and we were effectively directed to do that. Additionally, from the 1st of March, there was a new patient premium implemented, which meant that any patient that hadn't been seen in the previous 2 years could attract an additional £50 on top of what they would normally receive for either contract, depending on the level of treatment delivered. So it would be a minimum of £15 up to £50. That's in place. Additional to that was the launch of dental vans, not in London. We weren't even part of that process. They were effectively directed at areas where you've heard the term dental desert, where access to dentistry, particularly in rural areas, is extremely difficult. So ICBs were effectively given the opportunity to bid for the implementation of mobile vans. And then on top of that, there is effectively a scheme known as a Golden Hello scheme, which is again targeted at areas who find it hard to recruit. And there is an incentive payment for new dentists, and it's £10,000 over £10,000 a year for 3 years. Yeah. So in London, we were initially bypassed on that one, but they did come back to us and said we will allow you a level of access to that. So up to 8 posts in London have been allocated to us. And we're out at the moment to the individual areas are asking for expressions of interest. So that is, in essence, the dental recovery plan, which we were, you know, as a commissioning organisation, expected to transact.
So, the Smile for Life programme, will that still be rolled out?
Yeah, that's part of, well, whether it will be rolled out, because that actually is, so the bits I've talked about relate to the health side of things. The Smile for Life is all health promotion side of things, and that's being driven forward by local authorities. So that's with them. That's outside of my scope, if that makes sense.
It does. Does anybody know on the panel, though, if we expect that it will happen? Or?
I mean, we do know that the government has identified dentistry as one of the areas to look at, but we're not, you know, we're a bit like the contractual stuff, we're dependent on what's decided.
So the expectation is yes, because obviously until we're told otherwise, the expectation is that the dental recovery plan will be implemented, and that includes all of it.
And were any of you part of the consultation, or did you give evidence as part of the formation of the dental recovery plan? No.
Sorry, I didn't quite catch that.
Sorry, were any of you involved in providing evidence for the dental recovery plan?
There wasn't a formal evidence process that I'm aware of.
There was a consultation.
Yeah, I don't think whether you'd call it a formal consultation or not. I think they did speak to commissioning people around the country. What was sort of taken from that and then actually put into place, I couldn't say. But we were effectively given that recovery plan to roll out.
Yeah. Okay. That's what previous discussions I'd had, was that people had felt as though they'd been excluded from consultation on that plan, hence why I wondered if you'd been a part of it. Do you think that any effect from that plan has been seen in London?
In terms of the bits I related to earlier, yes, because they've all been implemented, and no doubt, particularly
Sorry, as an outcome,
it's a bit early to say. But I would say the new patient premium will have had an impact, and the reason I say that is non-recurrent. The new patient premium is only in place for this contracting year. It will be a decision, obviously, as to whether it's extended or not. But I would expect, obviously, there is an incentive there for practices to see new patients, because there is an additional tariff associated with it. But that will be capacity allowing. So it's not a given that actually, you know, will be universal. But I would expect there to be some impact there, yes.
Okay. So that's the dentistry recovery plan, not to be confused with the dentistry rescue plan of the new government. So one of the big points in there is the supervised toothbrushing scheme from 3 to 5-year-olds. Would you be keen, though, because I think the two things that these plans separately identify is the Smile for Life programme for 1 to 3-year-olds, and then a separate scheme for 3 to 5-year-olds. Would it be your gosh, I've lost a word. Would you be in favour of it being a scheme that ran from 1 to 5, or do you think that there is an age between there where it's more vital to receive that support?
I'll pick that up. So I'll give you a professional clinical point of view. I'm not a children's nurse, I'm a family nurse, but there's a received wisdom backed by evidence that caring for families as a whole has greater impact on life chances and quality of life lived over the decades. So we'd be really positive about anything that brings those things together, enables conversations with families to look after oral health from 0 through to 18 and then beyond. So absolutely, but given that they are the bits of initiatives that we've been given to date, then we'll make those work. What happens in effect, of course, is that these initiatives come and they seem to be piecemeal, but locally, local teams make sense of these things and say, I'm going to visit family X today, they've got a 1-year-old and a 4-year-old, we'll work with them to make sure. And that's what clinicians will do. They will make clinical sense of initiatives that come through. What is really important in the longer term is that those initiatives, as they're discussed at government level, at my colleagues nationally, and we get the edicts that Jeremy described, that those conversations now start to think about the public health needs of children and their oral health in the whole from 0 through to 18. But we'll make sense of those two different initiatives side by side.
Thanks. And yeah, that's a really good point, and that's something about the Smile for Life programme being closely linked to family hubs and doing that work, which hopefully won't be lost. And I think that's reiterated on the panel, so that's good. The final question I had was on another part of the dentistry recovery plan, but which also referenced the previous work on the NHS long-term workforce plan for dentistry training places, and I wondered if you had any thoughts on that specifically.
Again, because from a commissioning point of view, it's sort of outside of our remit a little bit. So the workforce side of things historically has obviously been dealt with, in a different area altogether.
Workforce sits with us as an organisation overall. We haven't got those details with us today. What we'll give you is the trajectory, as submission. We'll make sure that you get the details about number of current training places and proposed increase in training places over the next coming years. Sorry, I don't have that information today, but we can provide that for you.
I was just going to add, I think one of the training places are really, really important, but so is retaining qualified dentists in NHS dentistry. So there's a retention, attractive job challenge that we have to address in a market where, of course, there are options for individuals to do most or all of their work in the private sector as opposed to in the NHS. So there's a really important focus for us on the professional life they get to lead within NHS work.
Thank you. I'm now going to turn to Assembly Member Ahmad.
Thank you, Chair. Good afternoon, panel. Before I ask my question, I wonder if you could just backtrack on something that you said earlier, Jeremy, about why people from Black, Asian and minority ethnic communities don't access services in the way that other populations do. And if I heard correctly, one of the reasons that you gave is because culturally people think that they have to pay for services. What evidence do you have for that?
Most was anecdotal, but obviously that's coming from talking to dental practitioners themselves, because obviously quite a lot of the dental practitioners are representative of the communities they work in. And some of that is obviously driven just by their experiences. So they will obviously talk to people they know, or they're aware of families that have moved into the area, not accessing it. Why? Got to pay for it. No. You don't have to pay for it. And I think part of it is it's just that explanation around basically how the health service works, and particularly at a primary care level. So again, it's an assumption in some cases. It's not all down to that, and some of it is just down to the fact that in many cases, particularly where children are concerned, the assumption is to take the children, but obviously dental adults have to pay. So that can be a barrier as well, because actually, I don't want to go because I have to pay, I haven't got the money, that type of thing. So it's just one of a number of reasons, but it's definitely something that's come up over the years, because we talk to dentists obviously as part of our ongoing relationship, and they'll say, yeah, no, it is a problem. And also we've talked to other practitioners, so some of our pharmacists, because obviously people will go to the pharmacy as a first port of call if they've got a health issue, and that may be a toothache. Somebody says, well, why didn't you go to the dentist? Oh, no, I haven't got the money. No, you don't have to pay. So again, it's something that's borne out, and I think part of it's just about, again, it's that constant reassurance to people, and actually being able to get that message across. Because, children not accessing dentistry from a preventative point of view is really worrying, because that's the bit, if you get them in early, and again, it's that exposure to a dental practice from a very, very young age. So again, you wouldn't want it to be a scenario where someone doesn't take their child to the dentist because actually they think they're going to have to pay to access that service. So it's just that.
Thank you. And I did ask the previous panel this, and as a commissioner, I'd be very interested in your answer. What are the other reasons that are barriers to those particular communities?
I think part of it is, some of it's just, I don't know whether it's just a cultural thing in terms of accessing health services per se, and again, I think most of the major issue is around where they do have to pay, because actually that is but that's not just relating to that community, but it does seem to me more prevalent in some areas, and obviously in some parts of London we have a higher or a greater level of deprivation. So in particular areas, it will be regardless of where the patient is from. But I think it's just something that's generally, it has been a theme. It's come up from time and time again. And part of it is, well, how do you address that? How you get that message across? How do you, and again, some of that is in terms of the work that gets done locally, whether it be through some of these sort of neighbourhood teams that are effectively being set up now to actually just try and encourage people to come forward and actually make it clear that there are issues around accessing, or that they don't access it for whatever reason.
And what are those? So that's what I'm trying to get your perspective. What those other reasons are?
Well, most of the reasons are, in most cases, it will be because actually there's just a lack of understanding, and that may well be in terms of things like language and stuff like that. So obviously English not being the first language for a lot of residents, and that can actually be a barrier as well. Although there are obviously facilities available in terms of translation or the rest of it, it's not always that straightforward for people. And as I said, I think that there's some of the reasons. And again, in terms of the overall, there's a general position around people not accessing services anyway. But you can obviously see in the chart there that obviously in terms of the balance out, you could see that actually disproportionately people from ethnic backgrounds find it harder, or just choose not to access the services for whatever reason.
Sorry, just for the evidence piece, there was a brilliant review of evidence by the Race and Health Observatory done in 2021 of health services generally, including dentistry, but not specific to. And it found racism, because it was focused on race. There are other determinants in this, but let's focus on race for a second. That there was strong evidence over the years of institutional, systemic and interpersonal racism for people trying to access services, their experience of services when they got into them, and their outcomes afterwards were poorer. Now, that's quite a stark set of things for me as a healthcare professional to say, because I've never gone into a consultation or into work to exclude some people, but that is the lived experience of many Londoners today. They feel that the services are not for them. They feel that when they go to them, they don't get the level of experience that others do, and their outcomes are measurably worse.
And
so I think you need to be really frank that will apply in dentistry as it applies in everything else. And
life in general, sadly. But thank you very much for that intervention. But I'd like to go back to you, Jeremy, because of your specific role. So the committee here heard earlier when I was speaking about this to the previous panel and questioning that panel, having worked in the NHS at various levels over the years, one of the issues that I have heard for decades now is about language being an issue and it creating a barrier. I don't understand why we're still having this conversation. Why is that an issue still, given that we know about the languages in London in particular? Why is it that it's still a barrier?
Good question. I mean, I think it's one of those. If you're asking, do I know the answer to that? No, I don't. I think there are there's any number of services in place to try and counter that. I think one of the issues is, I mean, if I go to the use of interpreters, and again, it can be quite scattergun in terms of how people access that when they're pitching up. And I think going back to Martin's point just there, actually some of that is actually what's the reason behind either a practitioner making it difficult for someone who's trying to access services. And the three areas that I cover extend to optometry and pharmacy as well. So obviously anyone accessing those services, that can be a barrier. There are provisions in place, but some of the problems are in some cases that the practitioners choose not to go down that route and can actually make it difficult for someone accessing those services. So whenever it's brought to our attention, there's a clear directive around how interpreters should be used and accessed, and they are there so that patients can access services. So periodically we have to go out and remind practitioners this is the process. You know, they can access an interpreter, they are reimbursed for the cost associated with doing that, and they are available. So again, part of it's just about reinforcing the messaging that actually there are services, and that we will have, particularly in London, lots and lots of patients who require, and that's maybe the difference between them accessing the service and not at all. And the last thing we want is people to be turned away or to actually feel like they can't access services for that very reason. So, as said, in terms of why, there are provisions in place, but again, it's about effectively policing it to make sure that actually these things are happening so that patients can access services properly.
You paint actually quite a bleak picture and a very disappointing picture, but thank you. So the question that I would like to ask you, that I have listed here, is about the action, and this is to the whole panel, what action would you like to see from partners in London's health system, including the Mayor, to support preventative measures and improvements in oral health? And I think you've all touched on things, but it would be nice, as a closing question, to have an overview. So I'll leave you alone for a moment, Jeremy. Martin, let's start with you.
Okay. So you've heard all the way through, and you've just alluded to it, that there are things we can communicate better. There are urban myths that we need to bust, and there is work to do with our practitioners to make sure the services that are needed are offered in a fair and equitable way. So all London partners, we would and this is public health, other public sector organisations, the GLA and the Mayor's office as well, is to keep on echoing the key points. That access for children's dentistry is free and should be accessed whenever possible. Prevention is better than cure. I'll use cliches, but cliches are there because they are true. And we know that that's the case. That the result of poor oral health is catastrophic on the development of a child and appallingly painful for any adult who's had to go through it. And if all those partners and the Mayor's office can help us get those messages clearly across to all Londoners, whether they've lived like me for many years in the city or whether they're new to the city from anywhere in the world, that they understand that is what our dentist services are there for. And then there's something about how we work with the national partners to make sure that we work on the new contract and all of those things that might make a difference. But in the things that are in the gift of London, they're the things I would suggest.
Thank you. Will?
I'm absolutely into there's something for me about normalising from the start of life that good oral health is really important. So whether it's supervised toothbrushing, whether it's just recognising and understanding both for parents and for children the consequences of poor oral health, and that not just around direct cost in terms of treatment, if that's what's required in later life, but in terms of the impact for people in early adulthood and into older age, some of the evidence around people in care homes later on. There's so many things where getting into good habits about maintenance of good oral health are really important. So the more we can do to promote that, and it being seen as everyone's business. We've talked inevitably mostly today about dental treatment, but actually it's setting it in that broader context about healthy living and health promotion that is really incredibly important. Thank you.
Thank you, Jeremy.
Yeah, I mean, I'd echo both all the aspects that Martin and Will have alluded to. And again, I think part of it is this bringing together effectively what is seen as dentistry in terms of the treatment, but also that the prevention end is key, because the 2 points need to be brought together. Part of this is because obviously there's been a separation in terms of the commissioning of oral health promotion is local authority. Dental treatment, if you want, is effectively been that. Has been the remit of the health service. So the collaboration needs to go on. And again, in talking to our public health colleagues, you know, some of it basic, but things like supervised toothbrushing, if that could be done as a universal, that alone would make such a difference. And actually, again, it's the frustration, I think, at times is that will be done in some parts of London and maybe not in others. And you know, the evidence is there to support it. So, you know, from my point of view, something like that, and other oral health initiatives that are universal, so that it shouldn't be on the basis of, well, this is a priority for us as a place, but it's not really for us. Actually, universally, this should be something that's actually a priority for everybody, because going back to that start, and I think it's this that the dividend for that won't be seen for some time to come. And I think that's the problem with the short-termism, if you like, around, you know, whether it be parliamentary timetables, is that obviously everyone generally clamours for a very quick sort of evidence that something's working. Well, obviously you put something like an oral health promotion campaign like that in place, you're going to need to wait probably 9 or 10 years to actually see the fruition of that. But actually the long-term benefit of that in terms of the cost and everything else is huge. So I think the collaboration needs to happen sooner rather than later in terms of bringing both approaches together.
Great, thank you very much. Thank you, Chair.
Thank you. I'm just going to turn to Assembly Member Best, who had a question to ask.
Thanks, Chair. I mean, and just a comment quickly, the more I've heard it this afternoon, I just feel like the supervised toothbrushing may be the worst name of a programme ever. And it does have connotations of children lining up at a school gate ready to brush their teeth as they go into class one by one. And I hope perhaps to get greater support by that, perhaps we could hear evidence that supports calling it something like a oral hygiene programme or Smile for Life, some iteration of that. But my comment was coming back to Assembly Member Ahmed's point around language. And I was just considering there, obviously, the diverse nature of London, but also that means as well we do have a diverse level of staff within our dentistry practices. And is there no? And when you go onto the to find a dentist, you see the long list of details about a dentist. And would there not be a way in which, if there was receptionists that spoke another language, that could be added as a detail there? Because I was thinking about if I was in a country where I didn't speak the language and someone told me I had to organise an interpreter and then get payback, that would be quite daunting. But if I just saw English on the phone, I would feel a lot more confident about just picking it up and booking an appointment.
Good suggestion. Obviously, in terms of the detail, I mean, obviously, we're not responsible for the way that the NHS.uk website is built, and in terms of the detail on there. But what I will say is, in terms of the commissioned urgent dental care service in London, that facility is there because obviously you will get people ringing in from all over London, and they have a wide diversity of in terms of it's dental nurses that work there, but a huge range of languages spoken, and actually they have that facility there. If patients of a certain, from a certain part of the world, they are able to actually respond to that and actually do detail that they have these, languages spoken, but not an unreasonable suggestion at all, I wouldn't have said.
Maybe just also to be clear that the reimbursement is to the practice, so the practice organises the interpreter and gets the reimbursement. So from a patient point of view, that shouldn't be generating a problem, but clearly experience shows it is.
Thank you. Thank you. And an interesting point on the supervised toothbrushing as well. I've actually, full disclosure, I've had the pleasure of actually seeing a scheme in action in Brent, in my constituency, and that was in partnership with Whittington Health. So I can definitely vouch for sort of the benefits of it. Actually, we had a government minister at the time, public health minister, visit as well. So somewhere in the Brent archives there's a picture of me and a Conservative minister and children brushing their teeth, but I'll leave that for another day. Thank you. And thank you to all our guests for their contributions today. There will be a call for evidence as well going out, so your help and support in actually pushing that out to professionals and people you work with will be highly helpful, but also a public survey which will go out as well to get patient experiences and people experiences of using and accessing the system is due as well. So any help and support yourselves can provide and anyone watching online would be much welcome. So can we note the report and today's discussion, panel members? Yeah. Can we also delegate authority to me as chair in consultation with the party group lead members to agree any output from the discussion? And can we note the committee work programme and its meeting dates as approved by the London Assembly at the annual meeting on the 10th of May 2024? And the additional activity taken since our last meeting, namely the informal meeting of the GLA Health Team on 18th of June 2024 during the restricted period. The date of the next meeting of the committee is the 18th of September, and that is here at 10 a.m. again at City Hall. I have no other urgent business, and I therefore declare this meeting to be closed.
Thank you. Thank you.
This is the broadcast from City Hall, the home of the Greater London